The COVID pandemic caused widespread fear of rapidly spreading outbreaks among the homeless, as it did in nursing homes and prisons. However, in Boston, careful planning, quick situational adjustment, and near flawless execution have resulted in one of the biggest successes in containing an outbreak. This may be a model for outbreaks in other communities, combining the best of preparation, contact, case tracing, and isolation of all contacts, strategies that proved highly effective in Wuhan but have not been widely used in the United States. Dr. Jim O'Connell is a physician at Massachusetts General Hospital and an assistant professor of medicine at Harvard Medical School. Dr. O'Connell has devoted his life to the care of the homeless. As the founding physician of the Boston Healthcare for the Homeless program, he embodies the belief that healthcare is a basic human right, caring for Boston's homeless on park benches, down alleys, and under bridges. Dr. O'Connell, what is the special importance of planning for the care of the homeless during COVID-19?
Shelters are ordinarily life preserving and protect people from the extremes of weather and temperature, and especially here in the Northeast where it can get so cold. But as life-saving as they are, during epidemics of communicable and transmissible diseases, the crowded shelters become very efficient vectors of viral transmission, similar to prisons, nursing homes, cruise ships, and any other facility where so many people have to live closely together, breathe, and sleep in small areas.
You have a lot of experience with TB, HIV, hepatitis, meningococcal disease. Did this give you a head start in planning for COVID?
We have had a lot of experience with the sea changes in our healthcare system over these past 35 years of our program. As I look back, it's the periodic epidemics among homeless populations, all the ones you mentioned, meningococcus as well, Shigella, all sorts of things. And they continually teach us to be pretty flexible and that we have to be always ready to change or pivot our model of care to address a dire need, often things that are least predictable. So yes, in a sense, I would say that our program has been emotionally prepared for exactly these kinds of disasters. We, of course, feared this approaching tsunami and recognized that we had to change radically if we were going to be able to respond to what we were expecting to be a devastating illness in our population.
In congregate shelters, SARS-CoV-2 may spread rapidly as you expected. The most troubling finding was the number of asymptomatic. In 3 months, over 900 persons were diagnosed with SARS-CoV-2, almost 30% of the adults in the Boston shelters. Were you surprised?
Absolutely surprised, Bob. And we are still learning and still getting surprised. But the key thing that you brought up is that we had no expectation that so much of the virus was being transmitted by individuals who, I suppose the right way to say it is, had no symptoms at the time we tested them. And I can give you our first case in a homeless person was back in mid-March. It feels like forever ago now. And at that time in Massachusetts, as throughout the country, we were testing only those people who passed a screening test for fever or some sort of symptoms, usually shortness of breath and cough. And the information available at that time, as we all recall, had come from Wuhan. And in that case, the pandemic had been described primarily as a mountain rather than an iceberg. But I think we have learned since that transmission can primarily be by those without symptoms. So the epidemic looks much more like an iceberg to us.
Once you found that taking temperatures and looking for symptoms failed to contain the spread of SARS-CoV-2, what steps did you take?
In early April, the Massachusetts Department of Public Health allowed us, and they were very far-seeing, to do universal testing in a large Boston shelter. It was Pine Street Inn, where we had seen a very small cluster of cases, but they were our first cases we had seen in the homeless population. So we screened everyone at the shelter, as we had been just exhaustively doing all the time. We were screening every guest going into a shelter to make sure that no one with symptoms or fever got into the shelter and could cause an outbreak. So on this 2 nights actually in April, early April, 1st and 2nd, we were allowed to screen all 408 guests going into Pine Street Inn. And after screening them, we tested everyone. And there was only one person out of 408 who had a low-grade fever. And then about 10% of the other people complained of various kind of mild symptoms like coughs and things you might expect in a homeless population. Although none of them passed the screening test that we have to go on to get a real COVID test. But when the test results came back, and back then it was 48 hours for the test to come back, we found that 148 of the 408 people were positive, and a third of the shelter staff had turned positive. And we realized then that we had been painstakingly screening each guest coming into the shelter, but it was probably a waste of time because, in fact, 90% of the people who tested positive had no symptoms. So DPH allowed, after that, we were allowed to test the other large shelters in Boston and some of the smaller ones, and we found exactly the same thing. 30 to 40% of everyone in the shelters back in early April to mid-April and on had tested positive, and the vast majority, nearly 90%, if not more, had no symptoms at the time of testing.
Now that you've seen the speed of asymptomatic spread, do you think that airlines, schools, and even cruise ships are missing the nearly 50% of people who are asymptomatic with their current screening methods and risk rapid development?
I really do, Bob. I worry greatly. We are worried. Basically, if you screen and assume those without fevers and symptoms are okay, then in our situation, in a shelter situation, you're already lost the game. So we're thoroughly convinced that asymptomatic spread, and when I say that, I should be accurate, that spread by people who have no symptoms at the time they tested, because I know there's a lot of talk about pre-symptomatic and asymptomatic, but these are people who have no symptoms at the time you test them. And that has become a major challenge for us. So only time will let us know whether we're going to be right or wrong, but half of all deaths in Massachusetts have occurred, and even more than half have occurred in nursing homes and long-term healthcare facilities. And I truthfully suspect that the initial spread was probably asymptomatic in those settings. But by the time the first person was identified as sick, the virus had already been widespread throughout the unit. So, and we know, for example, that 50% of the people who tested positive for COVID on the Diamond Princess had no symptoms at the time of testing. Same thing for the soldiers on the USS John Kennedy. And so as we look back on that early phase of this global pandemic, I suspect that asymptomatic spread will prove to have been the Trojan horse within the bulwark of our public health prevention strategy.
So in Wuhan, public health officials were able to not just flatten the curve, but reduce their numbers of infected to near zero at one point. Their most valuable tool may have been contact case tracing, then the ability to quarantine every suspected contact in what they called mobile cabins. Your program is one of the few examples in the U.S. of containing the asymptomatic with known exposure by isolating them in separate pods with toilets. How much do you think this contributed to your success in containing SARS-CoV-2 among the homeless?
Sadly, when we began testing, the virus, was already, within the shelters, about a third of the people already had the virus by the time we really got testing. And what we learned there, those numbers were too large and too overwhelming for effective contact tracing to happen. So we have been very sensitized to how important it would be to do contact tracing, immediately isolate, immediately quarantine. But when we didn't realize about asymptomatic spread, I think we got behind the 8 ball. But at that time, we learned a lot because the immediate challenge for us was to isolate everyone who tested positive. And that was a third of the people in the shelters. So we had to find a place for them to go, whether they had symptoms or not. We knew that they could potentially pass on the virus. And so what we did in working with a lot of people and a lot of our community, the shelters, the hospitals, the city and the state departments of public health, the governor and the mayor, is that we converted one floor of our medical respite program, which is called the Barbara McGinnis House, into a COVID unit. So we had 52 beds that were really basically a COVID unit for homeless people. And we thought initially that was going to be plenty, But we learned as we tested that, there was 148 people on one day that we learned were positive at Pine Street. And then with a lot of help from people, we eventually opened up Boston Hope. And you may know a lot about Boston Hope. It's a fabulous place. But um, we had we had the privilege of overseeing 500 medical shelter beds for homeless and poor people who had been diagnosed with COVID in the Boston Convention Center, right adjacent to the very remarkable 500-bed hospital that was run by Mass General Brigham and overseen by Brigadier General Jack Hammond and Michael Allard of Home Base. And while thankfully we never needed more than about 200 of those 500 beds on our side of Boston Hope, this turned out to be the critical key for us. It was a place where as soon as somebody was tested, whether they had symptoms or not, we could bring them over there, isolate them, provide medical, psychiatric, and nursing care to those folks during quarantine and the recovery. And in addition to that, we could make it a place where people could have nutritious meals. We could do a lot of community building activities like bingo, and we had movies, and we had AA meetings, etc. And so removing those COVID positive people from the shelters into a safe place um, turned out to be one of the critical steps, because the shelters they were decanted by a third overnight. And then instead of being 500 beds and 500 people crowded in a shelter, you could bring it down to 200 or 150 people. And that over the system proved to be very, very effective.
So, contact case tracing and isolation was a big key to the success in China and is what the World Health Organization has been espousing since February. Nationally, do you think that this is just a big piece of the solution that we're missing?
So our experience, and we completely stand to be corrected as more information comes out, indicates that early universal testing before the epidemic hits large numbers allows us to do effective contact tracing, isolation of people, and prevention of further spreading. And as we learned the hard way, even though only a handful of people had been diagnosed at Pine Street that first week, the next week, a third of the shelter was COVID positive. So we missed a very key window. And we learned that we had to go test before symptoms, before there was an outbreak, in order to be ready to jump onto whoever tests positive and do the contact tracing. And now we've been doing that with a lot of help from everyone. The current positive test rate in the shelters is really below 2% now, after it had been up as high as 35 and 40%. And we can now do contact tracing. We still have our places to isolate and quarantine people, and the shelters within the city as well as the hospitals are still working so that we can have a coordinated approach to this.
We saw a tremendous surge of the virus through the South, including Texas and Florida and Arizona, and then threatening the Midwest. Do you think that what you've done with the homeless here in Boston would play a big role in being able to stem that spread in those states and future states undergoing outbreaks?
Start by saying that shutting down was absolutely critical in the states that were able to do that and effectively do it. But if you're trying to prevent a virus that has a significant amount of asymptomatic transmission, then universal testing, and I sound like I'm repeating myself, in crowded spaces such as prisons and nursing homes, shelters, becomes absolutely critical, because you want to be aware as soon as the first person or two turns positive and not wait until the virus has spread to half the facility. So small numbers still allow for contact tracing, which is really the key, and it can be done efficiently and rapidly. And you have to be able to test and get that test result back relatively quickly, within at least a day or two, and then you can do the tracing. I am absolutely appalled that we haven't been able to get our testing together in a better way, but I know that great things are on the horizon. And we spoke frequently with our state and city public health departments, as well as to the CDC. I remember the initial CDC recommendation was to wait for a cluster or outbreak of the virus in a shelter and then do universal testing. But we found that that strategy was flawed, because once the virus was in the shelter, it spread like wildfire. So we feel testing before the cluster appears in shelter settings is really the most effective strategy and should be employed for this vulnerable population across the country.
We saw in a New England Journal of Medicine case a homeless man where the individual had a range of comorbidities, ischemic stroke, type 2 diabetes, hypertension, hyperlipidemia, abdominal aortic aneurysm, hyperthyroidism, and obesity. How vulnerable is the overall homeless population?
This is a question that brings up one of the many paradoxes and the multiple uncertainties in our lives, starting with the asymptomatic spread, which was so surprising. But the homeless population that we take care of is exquisitely vulnerable and has an extraordinary burden of co-occurring medical, psychiatric, and substance use issues. And the incidence of diabetes, high blood pressure, lung disease, liver disease, and cancer is extremely high. So in our preparations for the coming virus, we were fearful, and several models confirmed this, that the pandemic was going to devastate our homeless populations in the country with high rates of hospitalizations and high numbers of deaths.
Why are you seeing a lower rate of infection and less serious disease in the homeless?
At the time when we first started, we were seeing a very high infection rate. But what we were puzzled by, and continue to this day to be puzzled by, is that we saw very little serious disease. We had about 12 deaths of the 900, and those were all in people with very debilitating illnesses who were elderly. And we're not sure why. One possible theory has been that maybe the virus that was let loose in the shelters is highly transmissible, but maybe associated with less severe disease. And whatever strain that is, we're working hard with many folks. The Sabeti lab, as you've talked to at the Broad Institute, is looking at the genomics of this, and we may learn that this is a less severe disease. We're baffled though, and we're certainly not at all in any way sure why that is. But sort of universally throughout the country, most homeless outbreaks have seen sort of less serious disease than we would have predicted, and certainly fewer hospitalizations.
The predominant theory of viral transmission has been that of large droplets. Yet, in an open letter to the World Health Organization, 239 scientists in 32 countries have outlined the evidence showing that smaller particles can infect people and are calling for the agency to revise its recommendations. To be clear, airborne means that the virus remains infective in the air and spreads over time and distance. Clearly, the final word isn't in, but from your experience, do you think it's airborne?
Our experience leads us to believe that it has to be airborne. That what we found in the shelters, and it wasn't just one shelter, it was all of the large shelters, is that with very few people exhibiting symptoms like coughing or the things you would expect to be creating the droplets, that people were getting, the virus was spreading. So we have to think that this has to be spread by people breathing, talking, doing all the things that suggest it's airborne as well as droplet transmission.
You undertook careful coordination and planning, creative alternate sites, and identification of those who were exposed and might be infected. How did you accomplish all of that?
Bob, as I look at this far end of my medical career, much to my chagrin, I have to salute our staff and the people around of being really truly heroic young doctors, nurses, nurse practitioners, PAs, social workers, recovery coaches, support staff. They were phenomenal. And as soon as the alarm was sounded, people literally changed their lives in order to care for these most vulnerable among us. And they did so with this huge set of skills, with compassion and dogged determination. And they worked tirelessly. And as you know all too well, we have clinics in virtually all the shelters in town, and we're anchored by daily clinics at Boston Medical Center and Mass General Hospital. These are homeless clinics. And we had to make a difficult choice to stop our regular activity and focus entirely on the coming pandemic. And that meant that people who were working in one shelter one day might be in a hospital-based clinic the next day. And even our dental staff, where we had to shut down our dental staff was some of the did the heroics in Boston Hope. They were taking care of people on the front lines. So the willingness of everybody to just stop what they were doing, change roles, or take on roles that would help, sort of showed us that there's an indomitable spirit, not only in our program, but throughout Boston. And I suspect this is repeated over many cities. But as a older guy who's on the sidelines because of being my age and stuff, it was unbelievably inspiring to watch what the people in our program really did.
The problem of homelessness is one of the most insoluble inequities in the United States. What fundamental human rights should the homeless have that could change this?
No doubt healthcare has to be seen as a human right and should be a human right. And I think we're all in agreement with that. But I think we also have to add housing as a human right, regardless of whatever it costs. And whenever we are woefully neglect in providing housing, severe health outcomes and costs to the system are incurred. So I'm a fierce advocate of recognizing that both housing and health are basic human rights.
Thank you so much, Dr. O'Connell. You've been an inspiration for so many of us with your tireless care of the homeless throughout your career, and now for demonstrating how outbreaks can successfully be contained in one of the most difficult of all situations.